everyone, welcome back. Now we will continue our discussion about premalignant lesions and the morphology of common mesenchymal tumors. After dissection, students should be able to define premalignant lesion and carcinoma in situ, recognize the morphologic features of dysplasia, lipoma, hemangioma, leiomyoma, and leiomyosarcoma, and finally describe the distinctions between carcinoma and sarcoma. Certain clinical conditions are well recognized predispositions to the subsequent development of cancer and are referred to as precancerous lesions or diseases. It is important for us to identify such conditions so as to prevent the subsequent cancer development. Some examples of premalignant lesions are given in this slide. Leukoplakia refers to dysplastic lesions on wet mucosal surfaces. Light bikeratinized squamous epithelium often appear as white color patches. Leukoplakia of oral cavity, vulva, or penis have an increased risk of squamous cell carcinoma. Adenomatous polyps of the colon are premalignant lesions with a significant probability of progressing to colon cancer if they are not removed. Some families have multiple adenomatous polyps inherited as an autosomal dominant trait. Virtually all patients with FAP will eventually develop colon cancer if the lesions are not excised. Intestinal metaplasia of the stomach is significant because some gastric carcinomas seem to arise from dysplasia of the metaplastic epithelium. Chronic ulcers of the skin sometimes become squamous carcinomas if they are not treated. Similarly, patients with ulcerative colitis are at risk of developing chronic adenocarcinoma. The term dysplasia has been commonly used for atypical cellular changes of the epithelium. Dysplasia is often preceded by or accompanied with metaplasia and hyperplasia. Therefore, it's also referred to as atypical hyperplasia. Microscopically, epithelial dysplasia is characterized by cellular proliferation and cytologic changes such as increased number of epithelial cell layers, disorderly cellular arrangement, cellular and nuclear pleomorphism, increased nuclear to cytoplasmic ratio, nuclear hyperchromatism, and increased mitotic activity. Dysplastic changes often occur due to chronic irritation or prolonged inflammation. On removal of the inciting stimulus, the changes may disappear. However, in some cases, dysplasia may progress into carcinoma in situ or invasive cancer. Depending upon the thickness of squamous epithelium occupied by dysplastic cells, dysplasia is conventionally graded as mild, moderate, and severe. In mild dysplastic epithelium, atypical cells are limited to lower one-third of the epithelium. In moderate dysplasia, dysplastic cells involve lower and middle thirds of the epithelium. In the next level of dysplasia, marked cytologic changes occupy more than lower two-thirds, but not the entire epithelium. Carcinoma in situ is the full thickness involvement by atypical cells with an intact basement membrane. If untreated, it could become invasive by breaching the epithelial basement membrane, and carcinoma cells could metastasize to remote organs or tissues. This slide shows the microscopic morphology of carcinoma in situ of the uterine cervix. The dysplastic cells have a disorderly arrangement involving the entire epithelial layers without evidence of invasion through or beyond the basement membrane. It's well accepted that invasive cervical carcinoma evolves through progressive stages of dysplasia and carcinoma in situ. Thus, detection at this early stage allows treatment to be given before local invasion and metastasis. This is the basis of cervical screening program. In the case of the uterine cervix, an alternative classification is to group various grades of dysplasia and carcinoma in situ together into cervical intraepithelial neoplasia. These micrographs illustrate a spectrum of morphologic alterations ranging from CIN1 to CIN3. CIN1 corresponds to mild dysplasia, and CIN2 is equivalent to moderate dysplasia. At times, severe dysplasia may not be clearly demarcated from carcinoma in situ. Therefore, CIN3 comprises severe dysplasia and carcinoma in situ. The following discussion will give some more details of common mesenchymal neoplasms. Benign mesenchymal tumors are relatively common in the skin and subcutaneous tissue where they are recognized by patients or physicians as small subcutaneous nodules or masses. Benign tumors of the uterine smooth muscle are among the most common benign mesenchymal tumors of visceral organs. On the other hand, malignant mesenchymal neoplasms are relatively uncommon. They tend to occur in deep soft tissue. They are often high-grade malignancies with a significant potential to invade adjacent tissue, to recur after treatment, to metastasize. Lipoma is a benign tumor composed of relatively mature adipose tissue. Macroscopically, it is composed of lobulated masses surrounded by a thin fibrous capsule, greasy on cut surface, yellowish in color. Histologically, lipomas consist of mature adipocytes. It often appears as a soft, very well-defined mass located in the subcutaneous tissues of the back or shoulder region. This picture shows the microscopic view of a lipoma. The tumor cells are so well differentiated that they are indistinguishable from normal adipocytes. These cells have a very small nucleus displaced to the periphery of the cell by a large globule of lipid. Hemangiomas are quite common benign mesenchymal tumors, especially during infancy and childhood. Clinically, they appear as dark red, soft, and sometimes poorly defined lesions, often located in the skin, mucosal surfaces, and liver. Histologically, they are composed of blood vessels lined by a single layer of mature endothelial cells. Although they are benign, they may have an invasive growth pattern. This circumscribed lesion is just beneath the capsule of the liver, which is typically an incidental finding. Actually, malignant transformation is unlikely to occur in such a hemangioma. Hemangiomas are usually divided into capillary or cavernous types. Capillary hemangioma is composed of capillary-sized, thin-walled, blood-filled vessels. These vessels are lined by a single layer of palm endothelial cells. Most of the capillary hemangiomas regress spontaneously within a few years. Cavernous hemangioma usually consists of large vascular spaces, some of which contain blood. The vascular spaces are lined by flattened endothelial cells. Leiomyoma is a benign neoplasm composed of smooth muscle cells. To the naked eyes, they are single or multiple, firm and well circumscribed. Microscopically, they comprise spindle-shaped smooth muscle cells. These cells form interwoven bundles with variable amounts of fibrous tissue component. Leiomyomas are most often found in the uterus, where they may occur within the myometrium, the selosa, or just underneath the endometrium. Section surface of the uterus in this picture shows multiple circumscribed, firm nodular masses of different sizes with characteristic whorl pattern. Histologically, a uterine leiomyoma shows whorls of smooth muscle cells which are spindle-shaped with abundant cytoplasm and oval nuclei. The smooth muscle cells are uniform in size and shape. The cause of uterine leiomyomas is unknown, but the possible stimulus to their proliferation is estrogen. This is evidenced by increase in their size during pregnancy and high-dose estrogen therapy, and their regression following menopause. Leiomyosarcoma is an uncommon malignant tumor as compared to its rather common benign counterpart. Typically, it arises in the uterus or gastrointestinal tract. This tumor is larger and softer than leiomyoma and often exhibits necrosis, hemorrhage, and cystic degeneration. This malignant smooth muscle neoplasm is much more cellular than a leiomyoma. The cells display pleomorphism and hyperchromatism. The degree of cellular atypia, the number of mitosis per high-power field, and the presence of zonal necrosis will aid in making this diagnosis. These tumors arise most commonly in the 5th to the 7th decades. They have a tendency to recur and metastasize. Malignant tumors are generally divided into carcinomas and sarcomas based on the tissue of origin. Indeed, carcinomas differ from sarcomas in terms of instance, morphologic features, and the way they metastasize. This slide summarizes the major differences between them. Carcinomas are more common than sarcomas, affecting more often in adults over 40s. Carcinomas usually are hard in consistency and white in color, while sarcomas are soft, moist, and fleshy. Histologically, carcinoma cells are often arranged in necks with distinct demarcation between parenchyma and stroma. However, sarcoma cells assemble diffusely without obvious boundaries between cancer cells and the supporting stroma. Reticular fibers are distributed differently in carcinoma and sarcoma. As we can see here, reticular fibers are located around individual sarcoma cells. By contrast, reticular fibers usually separate a group of cancer cells. In clinical practice, we can use some epithelial markers and connective tissue markers to distinguish carcinoma and sarcoma. Finally, we have come to the end of this chapter. Here are the macroscopic and microscopic appearances of a mass arising from the colon, which I show you in the first section. Now, I think you can answer these questions. These are the references. Thank you.